Welcome, everybody. So I start my talk with Martin Luther King quote. I have a dream. I have a dream that we will beat the Lima one day. And I think this stent or this platform, device, and implant will help us achieve it in the future, inshallah. Can we put the slides back? ولا أنا أسويها؟ خلاص. طيب. My talk is short and sweet, and thanks for the organizing committee for inviting me to talk about, I think it's the future. Disclosure, I'm sponsored by Elixir, so I'm biased by Elixir's product, but I think it's a great product. So we all know that the MACE, the outcome, the failure of stents are there, meaning the drug-eluting stent, be it the first generation, second generation, they all have the that we hate and we don't want to see in our patient, and we see it in our own population, especially if we're talking about the LAD, which is the most important vessel. As you can see, the curve is always going up for stents in any place in the coronaries, and that's what we're trying to solve with newer technologies. Even the concept of what Dr. Fawaz mentioned, leaving nothing behind, it's a great concept, and I've been adapting it with drug-eluting balloon, and many in the audience I know for a fact they're an adapter of drug-eluting balloon, and they use it because of the concept of not leaving anything behind. Yes, with the absorb, it's not as better with absorbed stent. It's not as good as drug-eluting stent when we reach the 2-3 years. They will be bifurcating with more events in the bioabsorbable stents. The same, sadly, with drug-eluting balloon, which I think it's also a game changer in the next future. We will be seeing a lot of people adapting the DCP de novo stenting instead of stenting, and the use of drug-eluting balloon, which is, again, it's a device effect, not company effect. So whenever you're using drug-eluting balloon, you should know which company you're using. Why we are focusing in the LAD, and I think the company investing their research and even the evidence did show that the use of this stent or this device or this implant in the LAD is far superior than the conventional stents that we use. The idea behind it, which we'll review it in the next few slides, that there is a lot of hemodynamic changes that happen when we cage the vessel. When we put a metal inside the coronaries, we literally jail that vessel to that size. And often vessels is a dynamic structure. It dilate and it constrict, and it even grow with time with positive remodeling if there is any effect of medication or even new atherosclerosis. So we are trying to solve that problem. Plus, also, if you can notice in the CT images, the LED is tortuous. The circ is often tortuous, the right is tortuous. Having this device is also key in tortuous vessel because it can maintain that tortuosity without making the vessel rigid. And in the guidelines, we're not talking about ACS, we're not talking about bread and butter stenting. In CCS, where people are shying from placing or doing PCI, yet for the LED, it's actually still a class 1 indication if medication failed. And in our population in the Gulf region, we know that medication always fails because of lack of compliance and lack of commitment to medication and the side effect that might happen from medication. So you can say that placing a PCI or LED PCI is a class 1 indication as per the European guidelines. So this is just a cartoon to show you how a regular stent, which we all see it, and when you stent a long lesion, a curved lesion, the natural curvature of the stent is lost when you implant a rigid stent. Yes, some stents perform better and different, but still, when you place a stent that is connected, that will not open and does not have that advantage from what we have with the Elixir's device, you lose that normal natural curvature. And this is by itself is a factor for restenosis and factor for failure of vessels. So, as we mentioned, it restricts the pulsatility, it restricts the normal or physiological factors that the vessel have, which is adaptive for the coronary blood flow. And we all know that having that caging increased the rate of restenosis, and loss of rigidity and pulsatility will impact even the restenosis, which we all fight. And that's what we see in the outcome of MACE being up to 13% after 2 years with the best stellar stents that we currently have. So what is the Bioadaptor implant dynamics from Elixir? It's actually a very innovative and very smart idea, whoever engineered it. It's a 3 helical, very small, 72 micrometer strut of cobalt chromium that are 3 and then connected with a bioabsorbable material that is covered also with drugs, that after 3 to 6 months it gets disconnected. And the aim of disconnect is to maintain, and you can see the video of it, to maintain the pulsatility of the vessel, i.e. slight growth of the vessel. And it gives it uncaging effect, so you don't lose the physiological factor that we advocate for it. It's actually a very brilliant idea, and I think based on the recent guidelines and the recent, the study that was published in Gulf EuroPCR, there was definite significant improvement at 3 years in terms of MACE compared to the best of stents. And the maintenance of the appearance of the natural appearance of the vessel is also something we don't lose when we implant this device. And I was arguing, and you can watch this video, which is the last video before I move to my next speaker. The worst thing that can happen, it's a stent, which we already implant. So that's the only worst thing that can happen. So the worst is the best of the regular stellar stent. But the best thing that can happen is to kill the lima. I have a surgeon in the audience, and my goal, hopefully in my lifetime of practice, to see a stent that will make us shy away from lima implantation. And I think this has a future, and it will hopefully be the stent that will be the lima killer eventually. So just to sum up, is it a game changing? I think it is. I'm a bit generous on the green mark on the dynamics, although some boxes can be utilized for the drug-eluting stents. If you implant it with IVUS and it's good, you can maintain the flow at 12 months. DCB, they are improving with time, but I think currently as we stand, this device, the Bioadaptor one, maintain the best practice for an LAD with the future maintenance of physiology that we want to keep in these patients. And with that, I thank you so much. We can move to Dr. Sultan Al-Ataibi's talk.